Good afternoon, everybody. We're going to get rolling because we have to. Okay, so the first talk will be, just a second, Sarah, Dr. Sarah Nisavako, okay? And she'll be talking about hybrid coronary revascularization, TCAB and PCI, okay?
Thank you. Thank you very much, and thank you for the opportunity to present. My name is Sarah Nisavako. I'm a first-year fellow. And on behalf of my co-authors, we were interested in examining in hybrid coronary revascularization what are the outcomes when the PCI does not occur. So that is what we looked at for this study. Here are disclosures. Hybrid coronary revasc with robotic beating heart TCAB and PCI is used to achieve complete revascularization. TCAB can be performed using 1 or 2 ITA grafts for multi-arterial grafting. And for various reasons, sometimes the PCI is not performed. So we performed a propensity match analysis of these patients who did not complete the PCI part of their hybrid compared to those who did. Between January of 2013 and May of 2024, we performed 874 robotic beating heart TCAB procedures. 45% of these were hybrid revascularization strategy or intended to be. And of these 392 patients, 82% successfully completed both parts of the hybrid, and 18% did not complete the PCI portion of the hybrid. So we did a one-to-one propensity match between these groups, and this resulted in 66 matched pairs that we compared for this study. For our TCAB approach, we've widely discussed and published this. In brief, we use the Da Vinci SI robot, given its ability to house the endo-wrist stabilizer. For hybrid strategy, I think everyone knows the different approaches. We most commonly do a staged approach with the TCAB portion done first. And this is an example of one of our hybrid TCAB patients who underwent multi-vessel grafting with beta. This is an angiography performed about 1 month post-TCAB. You can see a patent LITA to the LAD on the screen left, and a patent RITA Y graft to OM1 and OM2. And during this cath, they had a successful stent to their right coronary artery. In our matched group, there were no differences in demographics. You can see near 100% of patients in both groups had multi-vessel disease. The majority of patients underwent multi-vessel grafting, including with beta conduits. The mean number of grafts per patient in the complete hybrid group was 1.65 and 1.85 in the incomplete hybrid group. There were no conversions to sternotomy in either group, and there was no difference in LITA or RITA flow. And of note, we use TTFM to check flow in our cases after each anastomosis. These are the early postoperative results, no differences between the groups, as you can see here. When we examined for the reasons that patients did not undergo PCI, we found the majority were for a change in management. About a quarter of patients declined PCI, and 15% had attempted but technically unsuccessful PCI. Interestingly, when we examined the intended targets for PCI as part of hybrid, we found that in patients who did not complete their hybrid PCI, the majority of the intended targets, about 90%, were of the right coronary artery. And in the patients who did complete their hybrid PCI, a greater number, about 40%, were actually left-sided coronary targets, including left circumflex branches, diaphragmus, etc. These are results of early graft patency. You can see overall excellent patency results in the limited number of grafts examined, no differences between the groups. Midterm follow-up, this was 100% complete in both groups at a mean of 50 months in the complete hybrid group and 45 months in the incomplete hybrid group. The longest follow-up was almost 10 years in both groups. There was no difference in the incidence of mortality, all-cause, or cardiac, and there was no repeat cardiac surgery in either group. There were 3 myocardial infarctions in the incomplete hybrid group. This was borderline, but did not reach statistical significance. And repeat revascularization was not different between the groups. This was accounted for by PCI. There was no cabbage in either group, and no difference in incidence of midterm MACE. In conclusion, in our propensity match comparison of patients who did not complete their PCI part of their hybrid strategy compared to those who did, we found there was no difference in midterm mortality, repeat revascularization, or MACE. Myocardial infarction trended higher in the incomplete hybrid group, but did not reach statistical significance, though further studies, including larger studies with longer follow-up, are warranted. Thank you. Here are limitations, including small sample size and degree of selection bias, given our center is a TCAB referral specialty center. Thank you.
Thank you very much, Dr. Nisipavo. It's a beautiful, beautiful presentation. Undoubtedly, all those double mammaries will probably help that, because veins block in 5 years or 10 years, and mammaries don't. So well done. Very, very lovely. Thank you. Good. We're going to go on because we have a little bit pressed for time today. So the next speaker will be Dr. Philip Hayward. Oh my gosh, Phil. How are you? It's old home week. Okay, and we're going to talk about, just a minute, we're going to find my little thing here. The H graft, different configuration and strategy for surgical coronary revascularization. Phil.
Thanks for the opportunity to present on our experience of building an arterial ring around the heart to revascularize it, which I've called the H graft, which my secretary thinks is an example of my own narcissism. But basically, if most of the perfusion of most of the organs of the body is built on an arterial ring with little sub-branches coming off to the different segments, and obviously we know the circle of Willis, we know around the intestines, the superior and inferior mesenterics that join up, we know around the stomach, we've got the gastrics, left and right, that meet up, same around the liver, same in your hand where the radial and the ulnar meet up. The whole body's built on rings. And obviously this creates redundancy and provides protection for ischemia if one of them occludes. And it also allows for better auto-regulation if everything is just a little branch off a ring. There must be some evolutionary advantage to this because it seems to be common across the species. I'm going to take as a starting point that we assume that bilateral ITA is good for you, which I hope in this audience is reasonable. And certainly in Melbourne, we think that total arterial revascularization is the goal. We all know that the superior performance of the ITA graft to the LAD is really multifactorial. It's innervated and it can auto-regulate. It's got good size matching, so the physics of flow are good, and it runs off into the biggest territory. So everything is in favor of the LAD graft. But of course, most of the grafts that we do, and in Melbourne, the cardiologists routinely refer people for 5 or 6 grafts. Most of them will end up being aortocoronary grafts, and these are basically end vessels, which is the reverse of evolution. They've got unregulated flow, they don't collateralize, they've got too much inflow, much more than the runoff, and therefore you get stasis, and therefore you get endothelial injury. We try and mitigate that by giving multiple outlets through sequential grafting, but this only partially helps. So what I thought we would try is just building a vascular ring around the heart that mimics anatomy using bilateral ITA and one radial artery, because with radial angiography, we've now only got 3 arterial conduits available and sometimes 6 grafts, and double perfuse the radial from both ends by an ITA. So you do the liter to LAD as you normally would, and you jump the radial off it as a Y graft or a T graft, just as the liter comes through the pericardium in a standard way. And then the radial runs round the heart and grafts everything else. The reta, meanwhile, runs outside the pericardium in front of the hilum, and then just turns into the pericardium just in front of the IVC, where it can meet up with the other end of the radial artery. So this is a not very good schematic, but you can see why I called it the H graft. It looks a bit like a rugby post, where basically you've got the liter running to the LAD, you've got the reta either running directly to the PDA or maybe the radial extension of it if it won't quite reach. And between those two is suspended the radial artery going to the PLV, the OM2, OM1, and all the way back to the first diagonal, grafting everything else.
Wow.
So we got approval to do 20 patients as a pilot, and if there's time, I'll tell you at the end how we came to this idea based on one patient. And we did a pilot of 20 patients, just sequential, unselected patients that needed at least 4 grafts. We did it in a very standard way that we normally do with bilateral skeletonized ITAs, radial artery harvested open with a harmonic scalpel, and basically the only thing that we did was different was that we immediately put the radial artery behind the heart and measured that it would reach end to end from one ITA to the other, running around the back of the heart. Although I'm an off-pump enthusiast, I actually did all of these on-pump with blood cardioplegia, just because I wanted to minimise any technical variables within it. So I did a single cross-clamp technique. Basically, you join one end of the radial to an ITA, pre-bypass, and then on bypass, under cross-clamp, I did all the distals, and then the other end is the radial connected to the other ITA, all under single cross-clamp. I set out to do 20 patients. I did 19. I'll start at the bottom. One patient. The radial length was just marginal. You might have got away with it, but it was also a bit more calcified than I liked. So I was worried about length, worried about calcium, and I abandoned that one and just did a conventional operation. But the other 19 patients got the H graft as planned. 2 of them had other procedures. One had a Bentals with it and one had an AVR with it. And because they were unselected, they're the usual age range, 50s up to 80s. Just over about 2/3 of them were diabetic. And in true Melbourne style, they got at least 5 grafts, and a mean of 5.1 grafts for a full revascularization. It's my first 20 cases. It's not a quick technique. If you do 5 grafts, you've got to do 6 anastomoses under cross-clamp. So it was the cross-clamp time mean was about 89 minutes, although I'm getting a bit quicker. Post-operatively, as standard, we give all the patients dual antiplatelet therapy and amlodipine as a radial graft dilator, and we just did our standard. And I haven't put up all the results, but we had no post-operative concerns at all in terms of enzyme rises, ECG changes, echocardiogram changes. We had no evidence of post-operative ischemia at all, and no patient had any perioperative complication or stay in ICU. AF was just over half the patients, which seems to be about our standard. And then we put all the patients through CT angiography. It was intended at 3 months, but some of them have gone out to 5 months. And the one thing I did discover is you have to tell the radiologist exactly what the configuration is and what you're looking for. If you want to get these pictures like the top right there, they have to draw out the grafts and you have to tell them where the anastomoses are. I tried to mark the anastomoses with little clips because I skeletonized the radial at the point where there was a graft, so they could sort of follow the clips, but they have to follow the graft in between, so you can see the right ITA coming down, disappearing. The left ITA coming down, jumped onto a diagonal and then onto the LAD, and coming off the left ITA, the radial, which then runs round the back from here and then went across the back of the heart, doing multiple sequentials and joined up with the right ITA at the other side. Clinical review, as usual, all patients were completely well, free of angina, breathlessness or any other concerns. They all had 3-month echoes, no new regional wall motion abnormalities, and as I say, the CT angiograms were done intended at 3 months. Of the 91 grafts to these 20 people, 89 are patent, so it gives us a patency of about 98%, which I was happy with. There's a spasm of the distal LITA to LAD beyond, so the LITA gives off the radial artery Y, and then it touches down side to side onto a second diagonal, and it looks all good there. And then the final section between the second diagonal and the LAD looks to be in spasm, but I think it's competition from the LAD. I was never convinced by this LAD. It was at best a 50% lesion. The cardiologist persuaded me the FFR is positive. I think whatever graft technique you had used, this might have been a concern because I think it's competition from a very marginal LAD lesion. The other graft I've marked as a failure. I'm not actually sure it's a failure. They can't see the OM target filling. The radial's patent running proximal to it and distal to it. It seems to run nicely, and just the OM doesn't pacify well. And I'm not sure if you did a formal angiogram if it would light up or if it is a true graft failure. So I'm putting this up literally as a proof of concept, as technical feasibility. I think there are some putative advantages. You've got total arterial revascularization of 6 targets out of 3 conduits. I think the double perfused radial artery's got very high flow, and that may help against competitive flow against the native vessels. Obviously, like the rest of the body, the creation of a vascular ring would protect you against any sublethal damage to either ITA. If either ITA wasn't perfect, it would all flow from the other end, and we see that in theatre. The whole heart perfuses from either end. I think because you've got a ring just giving off little grafts, you can auto-regulate your flow better. You don't touch the aorta at all. And in fact, when you look inside the chest, other than the LITA to LAD segment, there's nothing to see. So if the patient needs aortic or mitral surgery, it's all at the back of the heart and facilitates redo surgery, I think. Obvious limitations, it is a multiple arterial sequential technique, so it was a little bit technically challenging. Obviously, if you had competitive flow from any one of those targets, it could, in theory, put the radial into spasm. So you've got to ask yourself, what would you do with a moderate lesion? I guess you could leave it out and for PCI in the future, or you could leave it out and put a standalone vein graft to it if you wanted. I did all of these on pump. I don't know how easy it would be to do off pump. I get the sense it would be just the same, but I haven't tried it yet. And the hospital I did these in, one of my 3 hospitals, has just got TTFM, but at the time I did these, we didn't have TTFM, so I can't offer you any flow measurements. But in conclusion, I think the creation of an arterial vascular ring for total revascularization, it's technically feasible. Clinically, the patients are all doing brilliantly. I've got no concerns about the patients, all the angiograms, and clearly I need to do some larger studies with some proper intraoperative flow measurements. But I think it's an interesting concept, and I'm very happy to be challenged on it.
Wow, Philip, thank you. I think you're brilliant. You know, blood flows every which way. Nature abhors a vacuum. So you're actually, in a sense, almost creating your own new collaterals as well as the bypass.
Correct. Yeah. I like to think of it as the circle of Willis for the heart, basically.
Yeah. Great. Well, we'd love to.
I'm going to call it.
Question. Okay, one question. Louis was behind time.
Hi, Pero from Montreal Heart Institute. Very elegant. You must be familiar that in the 70s, probably, with the snake graft. And it was very versatile. Obviously, it was a venous graft. And when everything went well, peachy keen, but when it occluded, the patient would absolutely die. So I think that the flow measurement is obviously important. In Quebec, we actually have extra reimbursement for measuring the flow on each graft to motivate the surgeons to do it. Yeah. Congratulations.
Yeah, I mean, although reimbursement-driven procedures can be problematic, I agree. I mean, we get reimbursed for removing the left atrial appendage, which means that people in sinus rhythm end up having their left atrial appendage removed, which is terrible. So, but I agree with you. We should be doing routine TTFM in all patients. I agree with you. I do in the other 2 hospitals. Teresa, of course, will agree as well. Unfortunately, the one centre where the cardiologist that was enthusiastic about this was based, and therefore these were all done in one centre, only just got the TTFM about 2 weeks ago.
Good. Well, thank you very much.
We'll be back. Thanks.
Okay. We're going to go on now to Dr. Guillermo Saito to present just a minute, how history of percutaneous PCI can influence outcomes in patients undergoing coronary bypass graft surgery. That's going to be interesting. Thank you.
Good evening, audience, colleagues. I have no conflict of interest. So, coronary artery bypass, we know that is the most common major cardiac operation performed, and the benefit of CABG over PCI has become more established even in patients with diabetes, left main disease, and multivessels or impaired ventricular function. But the robust data in patients with previous PCI is weak. And we thought that it was useful to indicate this patient for prospectively in the future for decision in the EAR team, given the spread of PCI that is increasingly common to find a patient requiring CABG up to 20%. And we enrolled all patients resident in Lazio who underwent CABG between 2008 and 2022. Our follow-up was 100% complete and certified by the Department of Epidemiology of Lazio. And a total of 20,000 patients were enrolled. Almost 80% were 90%, 95% had no previous PCI, only 5% with previous PCI. So this is a retrospective observational database and analysis using our regional database, and unfortunately this lost some clinical information because it's an administrative system. Operative or in-hospital mortality include deaths occurring 30 days after CABG, and we try to collect all patient information, linking an anonymous identification code for each patient with emergency system and tax register, including the life situation. Statistical analysis was regular. The two groups were quite different. In fact, we can see that PCI patients were younger and have a higher risk profile with more diabetes, more cholesterol disorders, arterial hypertension, pulmonary disease, and heart failure symptoms. And this data could be explained considering the failing of PCI or the disease, the advancing disease. But in the early mortality, we found that there was no difference in mortality between patients with previous PCI, with a 30-day mortality for all patients about 2%. We found as independent predictors gender, history of malignancies, heart failure symptoms, chronic kidney injury, urgent or emergency surgery, or severe reduction of left ventricle ejection fraction. We can see our long-term result in all patients. The two curves in the Kaplan-Meier are substantially the same, and this is found also in the normal left ventricle ejection fraction, but also in a slight reduction of left ventricle contraction and in severely poor left ventricle. And we were not able to find any difference in terms of survival. In the late mortality, we found all the cardiovascular risk factors that affect survival in patients that is already known. So collaboration with the regional health system make an important step of correctness and truthfulness of data, but this study of course has several limitations because this is retrospective. Several clinical and echocardiographic variables were not possible to investigate, and we found just only 5% with patients with previous PCI. We don't know if maybe some patients have denied for surgery for this. In addition, we were not able to identify the surgical techniques or mix and from standard surgery and the completeness of revascularization with venous or arterial conduits. In conclusion, we found that real-world data of cabbage in Lazio appears to have excellent results in terms of early and long-term survival with over 70% at 10 years, and our data suggests that previous PCI could not be considered as an independent risk factor for early mortality, even in case of very low ejection fraction left ventricle. And cabbage is a very safe procedure with long-term freedom from complication and death, even in this high-risk patient. Indication to PCI, so must be carefully assigned to avoid useless treatment, and cardiologists must consider that a last chance of cabbage must always be gave to this patient, or even in very poor left ventricle ejection fraction. Thank you very much for your attention.
Thank you very much, Dr. Saito. That's very interesting because we all say, oh my gosh, they've had 16 angioplasties, it's going to be terrible, but maybe it's because they only hit the proximal third, you know. That's why there is no difference. Thank you. I think that's a very interesting study. You're going to publish that, aren't you? You're going to publish that, aren't you?
Yes, we are going to.
Okay, well, we'll defer questions to the end if we have time, if that's all right, people. Okay?
Okay, thank you
very much. Okay. So now we'll go on to Dr. William Davalan for just a minute. This is Duragraft, which is an endothelial damage inhibitor solution on prevention of intimal hyperplasia in endoscopically harvested saphenous vein grafts. Dr. Davalan?
So thank you very much for this opportunity. So my name is William, and I'll be presenting this study on the prevention of intimal hyperplasia using Duragraft in endoscopically harvested vein graft. So this was a study led by Dr. Perrault at the Montreal Heart Institute. So just as a disclosure, this trial was funded by Merazyme. So Despite saphenous vein grafts being widely used, they still face high vein graft failure rates, reaching up to 10 to 20% in the first 12 months. So different solutions have been proposed to address these challenges, such as DuraGraft. So DuraGraft is a one-time intraoperative treatment to protect against damage to the structure and function of the endothelium. So it's a physiological salt solution that's pH balanced and contains glutathione, L-ascorbic acid, and L-arginine. So also just quickly, endoscopic vein harvesting is a minimally invasive technique for CABG that is known to reduce leg wound complications and to enhance recovery. However, there's some controversial evidence that it may potentially lead to lower long-term graft patency. So this study was actually a subgroup analysis of a broader study that aimed to determine the effect of DuraGraft in mitigating the onset and progression of vein graft disease. So this subgroup analysis focused on patients that underwent EVH. So the study was initially a multi-center prospective randomized double-blinded comparative within-patient study that included patients undergoing first-time isolated CABG for multivessel coronary artery disease that required 2 saphenous vein grafts. So each patient with the 2 saphenous veins graft, one was treated with DuraGraft while the other was treated with a control heparin-dosed saline. In terms of post-operative follow-up, every patient had clinical assessments and CT angio scans at 1 month, 3 months, and 12 months. So in terms of our outcomes and endpoints, our first outcome was to determine the structural and functional integrity of graft endothelium that was assessed by the changes in mean wall thickness. Previous studies have determined that mean wall thickness can play a role as a surrogate for intimal hyperplasia. Secondary outcomes included graft patency, determined by weighted average and mean lumen diameter. And then we had also supplementary safety outcomes that included mortality, vein graft occlusion, and MACE. So in terms of patient characteristics, we also compared EVH against OVH, and they had similar baseline characteristics, just except for EVH patients that had higher risk of complications and reoperation on pre-surgical assessment. Also, in terms of graft characteristics between grafts treated with DuraGraft and saline control, they had no significant differences. So in terms of results found on graft-specific CT assessments, we found a significant difference in the mean wall thickness at 12 months, with the grafts treated by DuraGraft exhibiting a much smaller, significantly smaller mean wall thickness at 12 months. And at the same time, we also noticed that in terms of the total vessel diameter, that DuraGrafts also had a smaller TVD at 12 months and a greater reduction from 1 month to 12 months during that same period of time. That suggests that DuraGraft may play a role in the pathology of remodeling of grafts. In terms of additional CT grafts measurements, there were no other changes, and more importantly, there were no differences in the lumen diameter across the entire period. In terms of adverse events, we didn't notice any significant adverse events in our patients, except for one saline control patient that had increased angina but was non-significant. So our key findings of this study demonstrate that DuraGraft treated grafts showed reduced mean wall thickness and total vessel diameter at 12 months with no significant changes in lumen diameter. Also, so this aligns with previously published studies that show that DuraGraft may play a role in mitigating neurointimal hyperplasia, and other studies more clinically have shown that DuraGraft may be associated with low rates of myocardial infarction and repeat revascularization. And so, as EVH has been associated with potentially higher rates of vein graft failure, DuraGraft may play a role in bridging the gap and reducing endothelial trauma caused by endoscopic handling. So the study still has some limitations, such as a limited sample size of 26 patients with only a 1-year follow-up period. And so there remains a need to have more extended follow-up studies with larger patient database to see the effect of Duragraft in more specific subgroups. Thank you very much.
Thank you very much, Dr. Davila. Beautifully presented, very well. We won't have any questions, but I just want to make a comment. I know that it's a tad expensive, and maybe that's the right case. Is a question? One? Yes, go ahead.
Study and the results. Fawad Gibran from Germany, Göttingen. I am, despite your results, a little bit disappointed from these solutions. We have done a lot of studies in animals first, rat studies where we did an autologous vein transplant and put the jugular vein, 2 hours in Duragraft. And in that time, there was a second solution available, which is, in my opinion, much better was much better. T-Protec, custodiol-based solution, and a third solution, and in this case it was just physiological saline. To cut it short, no big difference between the two solutions. And then we did a study with patients, saphenous vein, not harvested in this fashion, but in the normal way. And we did also put the vessels for 2 hours in both solutions. And you said treated, so I guess you had some time where the vessel was in contact with Duragraph, I guess. But we did then, in this case, vasomotoric testings. No difference between all the groups. So that's my experience. And I guess treating the vein as a surgeon is maybe the only way to get good results, and treating it in a good way and do not harm it. I guess the solutions, in my opinion, in my experience, does not really make the difference. But thank you for your effort, and I think we should go further with this and have more data, of course. Thank you.
Thank you very much for
Thank you
sharing.
for your comments. That's good. Thank you. Okay. We'll move on to Dr. Kazutoshi Tashibana, and he will speak on minimally invasive, minimally invasive off-pump coronary artery bypass grafting with and without, manipulation of the aorta, propensity scoring meta-analysis. Thank you. Tachibana.
So today, I'd like to talk about minimally invasive off-pump coronary artery bypass grafting with and or without manipulation of aorta. So shall I?
This is 319.
So to start with, I'd like to show you the background of my presentation. Advancing of the mixed CBG technique have enabled more safe and less invasive operation as CBG. This paper showed our group clinical data of mixed CBG performed by 3 surgeons with Dr. Keita Kikuchi and Dr. Yamauchi. So this is now mixed CBG strategy. Usually use fifth intercostal space approach, long shaft harmonic scalpel to harvest the litter in full skeleton fashion. The octopus noodle stabilizer to create working space with compressing right line. Anastomosis in off-pump fashion with 3 deep pericardium sutures. So these are our preferable graft configurations of mixed CBG. Our strategy of isolated CBG is directed toward obtaining complete revascularization of left coronary territories by using in situ beta grafts. About right coronary territories, in situ GA is used in patients with severe coronary disease as aortic notage technique. On the other hand, with no severe coronary disease, we prefer to take SVG relatively. In elderly cases, sometimes we choose the configuration with single IGA and vein graft. So in this study, we compared aortic notage with manipulation mixed CBG. So this is now group data. 64% of patients underwent aortic no-touch mixed CBG in this series. We matched 113 patients who underwent aortic mixed CBG and mixed CBG with aortic manipulation. So now, I will show you the patient characteristics. There are no significant differences between each group. Mean age about 66 years old, over 80% of cases have multiple disease. Diabetes was 50% of cases observed. Mean ejection fraction was about 58% relatively. So this slide shows intraoperative outcomes. Average distal anastomosis are 2.6 in aortic no-touch group and 3.3 in aortic manipulation group. Usual use of beta graft was 50% of cases in this series. Actually, in our all cases, about over 50% of cases underwent beta grafting. So one conversion to on-pump style was observed in aortic manipulation group. It's because of unstable hemodynamics. As for postoperative outcomes, early mortality was not observed in both groups. So one stroke was observed in aortic no-touch group on the third postoperative day, not in operative. Surgical site infection was observed in 4 cases of aortic manipulation group. So come up with considerations. We routinely performed enhanced CT scan for checking an aorta. In mixed CABG preoperative enhanced CT evaluation is useful for the appropriate selection of aortic manipulation technique to avoid intraoperative stroke. This strategy may ensure the safety of mixed CABG, I think. So in conclusion, mixed CABG could underwent with feasible perioperative complication rates through the appropriate selection of aortic manipulation technique. Thank you for your attention. Thank you.
That is a very lovely presentation, Dr. Tachibana. You've shown that you just have to vary things a little bit for different patients. I think that's excellent. Good for you. Nice. So we'll try to go for questions later if that's okay. All right? Okay. Thank you very much. Okay.
So I'll moderate the rest of the 5 presentations. We are extremely deep behind the schedule, so we're going to go ahead. So next presenter is Dr. Borobina Deminenko.
Good one.
Good.
Very well done.
So please come to on the stage. Okay. So impact of obesity on in hospital outcome after total coronary revascularization via anterior thoracotomy.
Yeah, thank you for the kind introduction. The topic of my lecture today is the impact of obesity on in-hospital outcome after total coronary revascularization via anterior thoracotomy. Here are my disclosures. The prevalence of obesity increased significantly since 1980 in the most countries, with some even calling it an epidemic. And as we all know, that obesity can be a special challenge in coronary artery bypass grafting. So let's have a quick view to the classification of obesity. In our study, we investigated patients with a BMI of 35 and more. That means an OB class of 2 and 3. The abbreviation TCRED means total coronary revascularization via left anterior thoracotomy. It is a minimally invasive surgical approach in the treatment of coronary artery disease. It's applicable to the vast majority of patients with a high percentage of multiple and total arterial grafting and shows promising early and midterm outcome. But the impact of severe obesity on TCRED outcome was unclear. Just a few points about our surgical technique. We enter the chest in the 4th intercostal space. We use a peripheral cannulation strategy for cardiopulmonary bypass and an aortic cross clamp and a cardiac arrest by using blood cardioplasia is performed. By slinging the ascending aorta, the left pulmonary veins and the inferior vena cava, an intrathoracic rotation of the decompressed and arrested heart is possible, and so all coronary target sites can be reached. All coronary anastomosis can be performed under a stable coronary exposure. Our study was a prospective study. In total, we included 502 consecutive non-emergent patients. Group A were 459 patients with a BMI of less than 35, and Group B were in total 43 patients with a BMI of 35 and more. The preoperative baseline characteristics of our patients are given on this slide. As you can see, the patients in Group B were significantly younger compared to Group A and had a higher rate of diabetes. The intraoperative data are given on this slide. As you can see, the use of left ITA, radial artery, the proportion of total arterial revascularization and multiple arterial revascularization, and also the number of distal anastomosis was similar between groups. What we found was a significant difference in the total operation time, but the time of cardiopulmonary bypass and the aortic cross-clamp was similar between groups. Our in-hospital results are given on this slide. Regarding to the MACE events, stroke, re-interventions, and mortality, there was no difference between groups. We were only able to show a higher rate of dialysis in Group B. Let me show you a typical patient of Group B with a BMI of 37 on the 6th postoperative day after total arterial revascularization using the TC-RED technique. So let me conclude. TC-RED can be effectively and safely performed in severely obese patients, is a viable minimally invasive surgical option for complete coronary revascularization, eliminates complications associated with full midline sternotomy, and severely obese patients may benefit particularly from this minimally invasive surgical option. Thanks for your attention.
Thank you very much. Sorry, I mistook your name, Dr. Selin.
Thanks.
Okay. Anyway, so you advocate, in case of the obesity patient, you advocate the minimal left thoracotomy instead of the mid-sternotomy because the result is the same, and that is your point.
Yeah.
Okay.
That obesity is no contraindication for this surgical technique. That's the point.
That's great. Thank you. So next presenter is Dr. Maria Canoletta. Is that right? So a retrospective analysis of 23 years single institution data of hybrid coronary artery revascularization.
From the Brompton.
So thanks, Mr. Chairman, and thanks to the committee to allow me to share our institution results in hybrid coronary artery revascularization. So as we know, CABG is recognized to be the gold standard for treatment of multivessel disease, and where the main advantage lies in the LIMA2-LED graft that we can see on the side, 23 years old LIMA2-LED. In our institution, to achieve this with a minimally invasive approach, we use atraumatic coronary artery bypass grafting in combination with the PCI in case of multivessel disease. So here we collected and we reviewed 24 years data, starting from January 2000, when we started the program, until this September. And we performed 1,194 endo-ACAB, and hybrid procedure were the 38% of these. So in this picture, we can see the setup for our mammary harvesting. We use harmonic scalpel with the aid of an ESOP robotic arm to control the camera position, which is under voice control. We use third, fifth, and seventh intercostal space as port access for the harmonic scalpel and the camera and the endoscopic grasper, as we can see in the picture. Then here we can see a completely harvested mammary artery, which lies just on the surface of the heart. Here again, we use the long needle in the middle that I hope you can see well, which to choose the best position for our mini thoracotomy. And here our mini thoracotomy through which we pass the lima and we prepare this in a standard manner. The LED is then exposed and stabilized with the endostabilizer, this metallic footplate, and the anastomosis is made in a standard opening technique with an intracoronary shunt. So in our experience regarding the timing, so this usually happens few days later, according to availability of cardiologist, or in elective readmission, and this is due to logistic reasons. We have cases of what we call a reverse hybrid with a culprit region treated acutely, which is often in a local hospital and then referred for the lima to LED to be done later. And very rarely in our cases we have endo-ACAB and PCI in the same sitting. This is more of a logistic reason. In our experience, the cases growth during the years, and we can see that the percentage of the hybrid cases increases very much during the years. And here we can see the conversion to sternotomy. In the beginning, we had quite a steep learning curve. And we can see that in the last few years we had no conversion at all, and the average is 3%. Most of the cases, this was because of pleural adhesions, which are mostly of the cases of conversion. Otherwise, we had hemodynamic instability or problems related to the lima harvesting or identifying the LED. In some cases, we managed anyway doing some Medistim ultrasound through the mini thoracotomy to find the LED, or difficulties in achieving the single lung ventilation. Regarding the hybrid cases, most of the cases had treated just one vessel in addition to the LED. So it was these were two vessels disease. In a minor percentage, two vessels or three vessels were treated with the PCI afterwards, and our percentage of reverse hybrid were almost 17%. So length of stay average was 6.2 days, and this, as we said, mostly because of the waiting time for the PCI. And these are our complication. We had no neurological complication. We had atrial fibrillation, 10% of the cases, some cases of acute kidney injury, pleural effusion, and we had a few cases, is 1.39% of infection of the thoracotomy, and these were all female obese patients with a submammary incision, unfortunately. And we have 0.7% of in-hospital mortality. So to conclude, we believe that hybrid revascularization with the endo-ACAB is a safe procedure, has got excellent outcome, and of course there is the limitation is further long-term follow-up of these cases.
Thank you.
Thank you very much.
So okay, so you have one question. Okay. Okay, I accept only one question.
We're into the...
Okay, so
yeah,
because
I
time is
maybe
limited.
ask afterwards,
Okay.
because we're into the coffee break.
So the next presenter is Dr. Youssef.
Yes.
The title is Robot-Assisted Multi-Vessel Total Arterial Coronary Vascularization, Single Center Experience.
Good afternoon, everyone. Thank you for the opportunity. We know multi-arterial has a reduced reintervention and improved survival, which again confirms from this large trial from the STS database with over 10 years experience, except in a small group of patients, elderly, obese patients, poor heart function, renal failure, and peripheral vascular disease. In select centers where patients have come off the learning curve, this review article looked at outcome from these small group of patients where it showed robotic-assisted procedures not only reduced recovery time and hospital stay, but reduced complications and mortality as well compared to sternotomy. So we routinely performed these procedures with a proper assessment. The preoperative assessment included pulmonary function tests because in the multi-vessel, need to keep them in single lung for a longer time. We use bronchial blockers now routinely for single lung ventilation. We exposed the groin in all patients who required either a right side graft or patients with LV function less than 40%. All patients are monitored with PA catheter and transesophageal echo during the procedure. So this was the technique which is standard, 3 ports. And we used a double docking technique when we needed longer mammary or in situ 2 mammaries, which the real advantages are it's easier to adopt by anyone who can do it from the left side, and it gives a longer length to complete 3 or 4 grafts comfortably. So following harvest of mammaries, we did direct anastomosis. The incision was smaller and with less retraction. So that is the end result with the patient goes home with. So they're extubated early, and usually single grafts, they go home in 48 hours, multi-vessels 3 or 4 days. The advantages of using the robotic assisted over minimal invasive, it gives total arterial revascularization, leb retraction, less chances of consolidation and collapse. There's no other cuts in the legs or in the arm. Shorter incision, it's not only kinder to the patient, but to the surgeon as well. There are certain contraindications. Not all patients do this. We have about 75% of our patients done robotic assisted. Previous lung surgery with dense adhesions is a no-no. Poor lung capacity, unstable patients, of course, we don't do them this way. And with more experience, relative contraindications turn out to be a non-contraindication. So these are our results in about 351 patients, average age 60, and about 10% of them were more 75 years of age, predominantly male patients. About just under 20% were moderate LV, and only 2 or just over 2% had very poor LV function. 15% had Euro score more than 3, and almost 75% were diabetics. So about 70% of this group had 2 mammaries taken down, and of this 351, half of them had 2 distal anastomosis, and in the remaining half, 50% had single, and the remaining 50% had 3 or more anastomosis. We started doing multi-vessel more than 2 anastomosis in the last 2 years, and have been gradually progressing. We had 1.42% mortality. We lost 5 patients in the group. And reintervention was 1.7%, of which 4 had PCI and 2 were taken back for surgery. Re-exploration includes the other 2 patients, 3 for bleeding. Average length of stay in ICU was 2 to 3 days. We conclude total arterial revascularization using robotic-assisted procedure is safe and efficacious and enables multi-arterial, multi-vessel coronary artery disease treatment. It needs further research and more surgeons adopting this technique. Thank you.
Thank you very much. So the multiple arterial grafting is possible, even robotic assisted CABG, but you increase the indication of this kind of procedure in the future?
Sure.
Oh, yeah. Okay. So any question from here? Okay, thank you.
Thank you.
So next presenter is Dr. Pettinari. Okay. Similar results at 1 year in female patients after coronary surgery, results from national database.
Thank you very much for the possibility to present this work that was made at the national level, thanks to the Belgian Association of Cardiothoracic Surgery and the database committee. Nope. Yes. So, as we know, one of the major topics in the recent debate is the inferior outcome of female patients after coronary bypass surgery. In this recent meta-analysis was and that was published in 2024, there was demonstrated that there was a significant difference in mortality when we collect data from propensity and non-propensity matched data, and also there was a significant difference in stroke in female patients. So the aim of the study was to compare and analyze the early results after CABG from a recent national database collection. And we used this outcome project that was performed by the Belgian Association of Cardiothoracic Surgery database committee. So we extracted non-emergent primary coronary artery bypass graft for the Belgian National Cardiac Surgery database. The primary endpoint was 1-year mortality. The secondary endpoint was stroke, postoperative atrial fibrillation, deep sternal wound infection, and reoperation. So in these slides, you see that the patient coming, for example, for the year 2021 was 11 centers. There was just a part of the total Belgian cardiac surgery units. There was a voluntary database, so the center can choose to send the patient the data or not. And you can see in 1 year collection, we have 5,500 total cardiac surgery activity in Belgium. So we extract about 3,000 patients from this analysis, and you can see the distribution of the female patient is about 60% in this group. So, as you can expect, the preoperative characteristics are different, and the female patients were older. They have more frequent in NIA class 4, and they have higher class of angina, and have a more frequent problem of diabetes with any treatment. So the coronary status, as you can see from this table, they have less circumflex artery disease and also left-right coronary artery disease, resulting in less three-vessel disease and the same degree of main stem lesion. The clinical presentation, we have similar characteristic in urgent case or incidence of poor left ventricle function and so on. The operative data, the total number of anastomosis was different. It was lower in female, but also coming from a number of three-vessel disease that was lower in this group. And the distal arterial absolute number of anastomosis was also lower in women. Just to notice here that the use of bilateral mammary artery in this data set, that was an all-comer data set, was quite high compare other national database, because as you can see here, the BIMA was using 40% or more of these patients. So the mortality at 1 year didn't different in this comparison. And also the other secondary outcome after reoperation for graft problem, bleeding, stroke or other cardiovascular event, dialysis, prolonged ventilation, was all these outcomes were similar. And also more specific coronary related outcome as sternal wound infection did not differ between the two groups. So from this national database analysis, despite a higher risk profile, 1 year outcome in female and men remained similar. So longer follow-up and other outcome probably would be necessary to compare and elucidate the difference in repeat need of reintervention. And an extensive use of bilateral mammary artery was demonstrated and could probably justify the very good results and quality of coronary surgery on national level. I thank you for your attention.
Thank you.
Thanks for the impressive result. I was so impressed. So it is a Belgian national database, and you guys, almost 40% of the patients,
yes,
bilateral, but on the other hand, the radial artery usage is only 2%.
Yeah, in Belgium, thanks also the possibility to have teachers as Professor Serjan, who teach, I can say 100, but very many of the surgeons that perform coronary surgery, there is a higher use of mammary artery. We present yesterday on national level
it's quite
results
similar in Japanese situation.
Sorry?
It's quite similar to Japanese situation.
Yeah, or even more.
I think it's because you use so many mammaries that women do as well. That is the key. They have smaller arteries, mammaries are the right size.
I cannot.
Veins are not good.
It's indirect demonstration, I think.
Well done.
Thank you.
Thank you, Paul.
Okay, the last presentation is the Dr. Dissenberger. Dissenberger, okay. The coronary computed tomographic angiography prior to cardiac surgery for infective endocarditis.
Thank you so much. I'm excited to present this to you today. It's not advancing. Oh, there we go. Thank you. All right, so for the evaluation of coronary artery disease before valve surgery, conventionally invasive coronary angiogram or left heart catheterization is recommended, particularly if the patient has coronary artery risk factors such as angina, reduced left ventricular function, a history of coronary artery disease, but coronary CT angiography is an alternative. Patients with endocarditis, we know they do worse after valve surgery compared to their matched cohorts, but patients with endocarditis are typically younger, so they have a lower risk of coronary artery disease. And we can match that with the fact that coronary CTA has a high negative predictive value. We also know that left heart catheterization has a stroke risk, and a patient with aortic valve vegetation can have a compounded stroke risk. And coronary CTA is a class 1 recommendation, although level of evidence C for endocarditis, and the ACC-AHA guideline, the ACR appropriate use criteria, and the AATS. So my hypothesis is that coronary CTA in patients undergoing cardiac operation for endocarditis is safe and feasible. But to be honest with you, I think this is obvious. I have bought into coronary CTA use as a screening tool. And so really, I think that this project is just to help convince others to do it as well. So this is a retrospective review. Patients who underwent coronary artery evaluation with coronary CTA with FFR were included, single institution. The use of CT was at the surgeon's discretion. We group patients into CABG that's planned and CABG that's unplanned, and it's 2015 to 2022. We identified 24 patients, majority male, and STS mortality predicted risk was 3%. So like I mentioned, it was already elevated risk compared to standard STS risk. About half were native valve endocarditis, and the most common operation was aortic valve replacement. So of the 24 patients who had the coronary CTA, 6 had coronary artery disease, so 25%. One of the patients did undergo left heart catheterization because it was unclear if the coronary disease was on CTA, and that patient subsequently had no coronary artery disease. So starting with the patients who had coronary artery disease, half underwent planned CABG, 3 and 3. Of the patients who had coronary artery disease but no CABG, 1 had a planned post-op PCI based on a heart team discussion ahead of time. 18 patients had no coronary artery disease, so the majority of patients. 1 underwent CABG, which was unplanned due to intraoperative complication during root replacement. Follow-up, 30-day follow-up, no myocardial infarction, no intervention for myocardial infarction, no death from MI. And late outcomes, patients were followed up at 24 months median follow-up. 1 patient underwent revascularization, and that was the planned PCI that we talked about. We were also able to see structural complications from endocarditis on the CT scan. 46% of the patients had an abscess, 13% had a fistula, and 25% had a pseudoaneurysm. So the advantages of coronary CTA and endocarditis is that it's non-invasive, there's no stroke risk, and you can see the sequela of endocarditis. And in the patients that needed CABG, planned or unplanned, CT scan did provide adequate anatomic guidance for revascularization. So in conclusion, coronary CTA with FFR should be increasingly utilized prior to operation for endocarditis to evaluate coronary artery disease, and I would also like to suggest a randomized control trial.
That's very nice.
Thank you so much.
Very good. Thank you.
Thank you. Very, very good, great results. So you're going to expand the indication of the CCTA or after because these are the patient number is only 24 patients. But after this result, you're going to start expanding the routinely what to perform CT.
Yeah, I mean, I'm one of the surgeons who ordered these CT scans, and my partners as well. So I think it's a great screening tool for endocarditis patients. And, you know, we saw yesterday, one of the presenters talked about using CTA in a randomized trial, and that has value. So I think the endocarditis patient is a no-brainer.
Yeah, exactly. It's common sense.
Thank you.
Thank you. Thank you very much, Brittany.
Thank you very much for your cooperation.
guys.
We could finish this session.
You've got 8
before,
minutes to have coffee.
Yeah, only 8 minutes for the coffee.
Yeah, eight.
Thank you.
Okay.
Thank you.
Right, thank you.